All right, let's get right into it. We're talking about one of the most sudden, most dramatic, and most life-threatening emergencies in all of medicine. This is a catastrophic event happening inside the brain, and it is, quite literally, a race against time.
You know, sometimes a whole medical drama can be summed up in a single sentence. For a subarachnoid hemorrhage, this is it. The worst headache of my life. When a doctor in the emergency room hears those words, alarm bells don't just ring, they go off like a siren.
And let's be crystal clear here. We are not talking about your garden variety migraine. This is something else entirely. They call it a thunderclap headache for a reason. It's this explosion of pain that hits its absolute maximum intensity in under a minute. It's a sign that something inside your head has gone terribly, terribly wrong.
So let's talk a little more about this warning sign because it's so important. Beyond that excruciating headache, patients often experience things like projectile vomiting, a really stiff neck, so stiff you can't touch your chin to your chest, and something called photophobia, which is just an extreme, painful sensitivity to light. All of these are clues that something is seriously irritating the central nervous system.
But what is actually happening to cause such a violent reaction? What could possibly be going on inside the skull to trigger this? Because this isn't really a headache, it's a symptom of something much more serious. It's a bleed. So the real question is, where is this blood coming from?
Well, the event itself is called a subarachnoid hemorrhage, or SAH for short. The easiest way to picture this is to think of your brain as being wrapped in a few protective layers. One of those layers, the subarachnoid space, is filled with fluid that acts like a cushion. An SAH is like a pipe bursting and flooding that cushion with blood, a space where blood absolutely should not be. So, what causes that pipe to burst? Well, in the vast majority of cases, we're talking a massive 85% of the time when it's not caused by trauma. The culprit is a ruptured brain aneurysm. An aneurysm is just this weak, balloon-like bulge on the wall of a blood vessel, and under pressure, that weak spot can just give way. And that, of course, brings us to risk factors. Now, some of these are genetic, things you can't control, like a family history or certain kidney diseases. But two of the absolute biggest risks that you can control are high blood pressure, hypertension, and cigarette smoking. Both of those put incredible stress on your blood vessels, making it much more likely for one of these weak spots to form, and eventually to pop.
So, the second a patient comes in with that thunderclap headache, the clock is ticking. The first mission for the medical team is to confirm there's blood in the brain. But the second mission is just as critical. Find the source of that bleed before it can happen again, because a second bleed, a re-rupture, is often way more catastrophic than the first.
All right, so how do they do it? The first and fastest step is a non-contrast CT scan of the head. It's fantastic at spotting fresh blood, especially within the first 6 hours. But if that scan comes back clean and the doctors are still really suspicious, they move to a lumbar puncture, a spinal tap. They're looking for evidence of blood in the spinal fluid, specifically a yellowish tint called xanthochromia. It's the telltale sign that blood has been there. And once the bleed is confirmed, they use angiography to create a roadmap of the brain's arteries to find that aneurysm.
Okay, they've found the aneurysm. Now, a whole new race begins, securing it. The goal here is to stop it from rebleeding, and the highest risk for that is in the first 24 hours, so this becomes an incredibly urgent procedure.
And there are basically two main ways to do this. The traditional method is surgical clipping. This is open brain surgery, where a neurosurgeon puts a tiny metal clip right on the neck of the aneurysm, basically pinching it off from the blood supply. The other path, which is less invasive, is endovascular coiling. Here, they thread a catheter all the way up into the brain and deploy tiny platinum coils inside the aneurysm, packing it full so that blood clots and it's sealed off from the inside.
Now, you might be thinking, okay, they secured the aneurysm. The danger is over, right? Well, not quite. The battle isn't over yet. All that blood that already spilled into that protective space is still there, and it acts as a massive irritant to the brain, kicking off a whole new phase of dangerous complications.
The threats really evolve over time. After you get past that initial risk of a rebleed, the patient enters this new danger zone. It's a window that usually lasts from day 3 to day 14 after the hemorrhage. And the new enemy here is something called cerebral vasospasm. The risk for this peaks right around day 7.
So what is vasospasm? Well, as that old blood breaks down, it releases substances that are super irritating to the brain's arteries. In response, those arteries can start to constrict and narrow. They spasm. This dangerous clamping down can choke off blood flow to parts of the brain, and if it's bad enough, it can cause a delayed stroke. It's a really feared complication.
So, is there anything we can do about it? Yes. The main weapon in this fight is a drug called nimodipine. It's a calcium channel blocker, and it is given to every single one of these patients for a full 21 days. It's one of the only medications that's actually been proven to improve their outcomes by reducing the terrible damage that vasospasm can cause.
Wow. Okay, we have covered a ton of ground here following this intense race against the clock, so let's slow down for a second and just boil it all down to the absolute must-know critical takeaways.
First, I want you to just look at this number, around 18%. That's the percentage of people who have one of these hemorrhages and don't even survive long enough to get to the hospital. That statistic alone tells you just how lethal this condition is, right from the very first second.
So here it is, your ultimate cheat sheet. If you take away anything from this, let it be these points. The classic sign, that thunderclap headache. The number one cause, a ruptured aneurysm. The first test you get, a non-contrast CT. If that's negative but suspicion is high, you get a lumbar puncture. The key medicine everyone gets, nimodipine, and the fix, either clipping or coiling. That is the core of managing this emergency.
So we'll end on this question, which I know you can answer by now. What's the one symptom you should never, ever ignore? It's that sudden, catastrophic, worst headache of your life. That's not something to just take a painkiller for and lie down. It's a sign that you need help immediately. And recognizing that could be what makes all the difference in winning this race against time.